Welcome medical students, interns, residency staff, and the cardiology fellows who are aspiring to take their boards exam, whether it's for internal medicine and or cardiovascular, echo, or nuclear boards. I know this is commonly an asked question, which test would you advocate for which patient in a which clinical setting? There's been a dearth of information across the text I'm sure you've gone through, but this is a quick video vignette in about 5 to 7 minutes. I want to quickly give you an encapsulated way to understand as to which tests are required for which conditions and indications, etc. So without delving into anything else, let's jump into straight talking about a stress test and various indications. If an EKG is normal, always use a plain ECG stress test. Why? Because one, it's an excellent routine screening test available for CAD evaluations. And two, for all high-risk individuals, like maybe for a policeman or for a train engineer or a pilot or somebody who wishes to join an exercise gym program, or a school bus driver with 30 kids who wants to drive throughout the year except the summer, I believe, with all the crazy kids behind. There is a stress involved in all these high professionals. So even though they may not have any symptoms, but you normally clear them for various professions. Pilots, for instance, they require, I think, pretty much every 6 months based on the FAA requirements. Things like train engineers, specifically so. So in clinical practice, you will see, and there will be, time and again, either on the boards or in real clinical practice, you will come across these patients, and when they come in for just clearance, like a football player, an 18-year-old, the mom brings the person to your clinical setting and say, look, I want him or her to be cleared because the person has a murmur or something. So start with a plain ECG stress test always. One, it'll define the physical ability, the physical endurance on that patient, and also because you have an EKG which is baseline normal, the chances are you will be able to make a great interpretation of it, unless it's an uninterpretable EKG, then it's a whole different story, and you have to get into the other more specific testings. Stress echo. What is a stress echo? Stress echo obviously combines an echo right here shown to you, and then of course you're doing it on a treadmill. So what it does is it really allows you to assess the wall motion abnormalities, one. Two, the valve functions, which are mainly the aortic and the mitral you're concerned about. And then it also gives you an idea as to whether the ejection fraction improves, stays flat, or declines during the stress test. And then, of course, you combine that with the EKG that's being analyzed at the same time when the person is exercising. So you have a dual info available to you, both EKG and imaging-wise, in a quick format, and you can assess, and before the person leaves, you have an idea whether the coronary artery disease or the symptoms are related to one or the other. So you would be able to assess that rather quick. Again, it's normally done when it's a preferred test when you have an abnormal EKG to begin with. It's easily administered, no radiations involved. Obviously, ultrasounds, we know they are the safest, even in pregnancy. Another caveat to this is when you're evaluating a person with aortic stenosis, specifically so with the critical AS and or 3 moderate MR, 3 plus 4 plus MR, one likes to know what the ejection fraction response is during the time when the person is exercising, one. Two, and during the time when somebody's receiving a dobutamine stress echo, because a suspected critical AS with a low EF and a low gradient will perform much differently during the dobutamine stress echo, because then you would expect the critical AS gradient to increase, and the EF will also increase in that individual. Whereas if the EF does not increase and the gradient improves, then you know we have a problem with the CAD here, as opposed to just the valve. So it's a very interesting way of knowing what dobutamine stress test can offer in a setting of aortic stenosis. And of course, mitral regurgitation is a very, very important entity which is also being evaluated now by stress echo increasingly. I remember the years when I was training, it was all by nuclear scans. We used to do the mugger scans, if you will, for MR and AR both. And in fact, the entire data of nuclear has been based only on MR and AR, primarily evaluations prior to surgery, to indicate whether or not these patients should be sent for surgery. There, the golden standard is, still the gold standard is, that if the ejection fraction stays flat or drops by 5% and more during the stress test, during the nuclear stress test, MUGA scan stress test, if you will, or even the MPI, if you will, because you'll be able to assess the ejection fractions, then one can tell that the AR or MR needs to be fixed surgically. Okay. Coming to the pharmacological stresses, well, we just touched upon the dobutamine part of it, but normally it's done only when patients cannot walk on a treadmill, and or if you're assessing the aortic stenosis and the gradients and evaluating a combination of aortic stenosis and CAD when it's suspected together. Myocardial perfusion imaging, which is nuclear, obviously, you're using technetium-99 or you're using the thallium-201. Those are the two major isotopes still in vogue for the last several decades. And the only thing that you have to exclude is pregnancy, and then invite the person into your lab. So just be careful first to make sure the patient's not pregnant. And then at that point, just explain that there's some minimal radiations involved. Obviously, it's a little more time consuming than a stress echo, which only takes roughly 30 minutes. This may take about half a day, depending upon the protocols you use. For those, I'll refer you back to the text because that's beyond the scope of this video discussion. However, if you're doing a nuclear stress test quickly, you can get the imaging the following way. The short axis obviously is represented in this fashion. So during the stress, what happens is you will have a defect, say, in the lateral portion and a little bit of inferior portion. So automatically it's an RCA or a CIRC territory, and during rest it comes back. So it's a filling defect which is reversible that gives you an idea of a two-vessel disease. Same thing is here. The LAD is involved, and this territory will not light up during the stress and then eventually fills up during the resting phase. So they show you this, or if you see this in clinical practice, you know there's a reversible mechanism here and or hibernating myocardium, if you will. But the key is that if it stays like this, then it's a fixed defect, and obviously you can't do much about it. So that's a non-revascularizable or non-amenable to surgery or to PCI. So it's an excellent test to ascertain myocardial viability. Obviously, you're improving about 80 to 90% of your specificity and specificity rates and sensitivity rates. You could use adenoscan or persantine as in lieu of the treadmill, specifically if the patients are not able to walk on a treadmill. But sometimes I like to still walk them at a very slow pace, even if they're not able to exert so much. So, you could still walk and you can actually get a better scan imaged when they're not able to walk on a regular Bruce protocol, etc. So, and it's very, very helpful, by the way. The myocardial perfusion imaging, pharmacological stress testing is extremely helpful for a pre-op evaluation prior to non-cardiac surgery. Specifically, somebody's going for abdominal, thoracic, prostate, thyroid, all these vascular, surgeries involving tremendous volume exchange, etc. So all of those definitely need a pre-op evaluation, specifically so if you have a abnormal ECG stress test to begin with, or an abnormal ECG at baseline to begin with. Okay, well, this was a quick run-up, if you will, on proper stress testing to evaluate CAD and how to select in individuals given to you. Okay, stay tuned, and many, many more, and please watch MuniMeterHealth.com on my Facebook and my website, and I'll continue to teach and